So this is Penny and Laurel about social prescribing in Shropshire.
Hello. Oh gosh, you can't see now, I've got my glasses on. My name's Laurel Roberts. I work for Cube in Oswestry that Daphne's just been talking about. This is my colleague Penny, who is the STP Programme Manager. And we're doing a double act for you this afternoon because Shropshire, social prescribing in Shropshire has been developed as a real partnership approach, and we wanted to reflect that even in our presentation. So we'll go on to the partners in a moment, but I just wanted to just go through exactly what social prescribing is for those people who aren't familiar with the term. And it's defined as a non-medical intervention for people who are facing difficulties in their lives for which a medical treatment is not appropriate. How it works is that a person is referred either by a GP or another referral agency to see a social prescribing advisor. That advisor meets with that person usually for around about an hour. They have quite an in-depth conversation, and the advisor listens to the difficulties that that person is facing, what their concerns are and what issues that they have in their life. And then together they create a plan which will help that person to move forward and make a positive change. And quite often that involves joining or attending a service that's delivered within the community. So an example might be someone coming with pre-diabetes might be encouraged to get some healthy eating advice, but also to join a walking group, or someone who's lonely and isolated could join one of the groups that Daphne has just been talking about. So, as I said at the start, social prescribing model has been developed over the last few years in Shropshire. I think it started in 2017. And it was started by Public Health within Shropshire Council. So they have been working and really developing the model over that time. They've been supported by the CCG, who represents the GP surgeries, and more recently the primary care networks. The primary care networks are also partners with us now, along with adult health and social care too. Social prescribing started as a pilot in Oswestry, which is when Cube became involved, and all of our fellow voluntary organisations. And we've been doing some work within the community to support that, which I'll talk about in just a moment. Other partners we've had mainly are referral partners, people who want to send people to the scheme, and they tend to come from the job centre, libraries, leisure centre, anywhere really where people might go to get advice. Oh, you can say that,
yeah. So it's just something, oh thank you, just something that we wanted to sort of say at this point about the social prescribing model in Shropshire. So as described by Laurel, that's the way social prescribing looks for this particular model that we're talking about. But as we were developing it here a few years ago, we recognise that there's an abundance of social prescribing happening in the county, and there's an abundance of goodwill and community spirit and volunteering, and a number of ways in which people in the community have been connected to all of those schemes and those things that we've been hearing about today. And we didn't want to duplicate anything that was already going on. And on top of the voluntary and community sector, there was also the Let's Talk Local sessions that Shropshire Council puts on, and there's also the community care coordinators that work within and with GP practices, ensuring sort of continuity of care for those people who are in need. And we wanted to take stock of all of those things at a first port of call and kind of decide, is there room for something else in social prescribing? Is there more that can be done to support people? Because as we've heard today, there still seems to be an abundance of need, and people who in our communities who are coming against struggles and thinking about, and do we need more ways to support those people? So we did this scoping exercise that looks at all of those things, and we also looked at what's happening elsewhere in the country and other countries around social prescribing. So there's some schemes, Bromley by Bow, and there was one in particular that we were really keen to look at in Halton, which is near Liverpool. And we all got on a bus and we trundled up there, and we had spent the day with the Halton community, and we worked and looked and understood how they developed their social prescribing model, which was purchased there by the CCG. And we were really impressed, because what it did is in many ways similar to the model that we've developed, which was that really intensive one-to-one support with people that provided, at the beginning, a minimum of an hour with people to talk about their needs, not necessarily the reason they were referred, but actually those things that are really important to those people. And we know across our system we already do this, but I suppose the difference might be slightly in the ways in which people arrive at social prescribing through a concerted joint effort, through the GP practice, through others, through the job centre, through social care. And so it was just this that I wanted to mention, that the journey that we went on to arrive at this model that Laurel has described so well was around looking and understanding and working then with our voluntary sector and our partners here to understand how we could make the best of what we already had. Because we didn't have any additional money to put into this, we needed to think about different ways in which we could work together. Back to Laurel.
Thank you, Penny. Can we have the next slide? So what is the social prescribing model that we've developed? This is a difficult slide to read. You don't really need to read it all. Sorry that it's not so clear. But the GP practice is at the very heart of the model, everywhere it's rolled out. And they really set the priorities for their social prescribing in their surgery. And that might be that they have a lot of people with cardiovascular disease. It might be that they get people coming to the surgery who are lonely and vulnerable. And so they say how they want it to work. And then down in this purple sector here, we have the project manager. They liaise with the GP practices. They talk about what their priorities will be, how they would like it to run in their practice, and then they go away and they organise it basically. The green section in the middle, those are the social prescribers. Those are the people who are doing the one-to-one meetings. They meet either in the surgery or sometimes in other venues, and they take people off and support them with the activities. And then next to them, in the brownie section, that's the lead advisor person. Sometimes the social prescribing advisors are hearing some quite complex stories and quite difficult stories to listen to sometimes. So it's really important that they're also able to get support. And then up above that we have the community development role, which is the bit that I've been most involved in. And what we've been doing is everywhere that social prescribing is being rolled out, we've been gathering community information. We've been sharing with the community and with voluntary organisations what's going on, how it works. And then we've been gathering information and building directories of services, because social prescribing only works if there are services within the community for people to be referred to. So we've been doing that, and we've also been working on the quality assurance framework and signing individual organisations up to that. It's a very light touch framework, but it does give assurance that the people who are being referred are going to services that have the appropriate things in place, like safeguarding, insurance, that the staff and volunteers are trained, all that kind of really good practice stuff. And then up in the uppermost corner, last but not least, is the data lead. The data lead is the person who does the audits with the GPs, who looks for people who might benefit from being referred to the process. They also track the people who are within social prescribing, so that we can find out what's happened to them, and we can ensure that it's made a real positive difference both to the individual but also to the surgeries. So, handing back to Penny.
Thank you. So our case study is a woman named Sarah. Now, she was referred to the programme via her GP. She had been known to services previously, and had tried to sort of get on top of some of her complex issues in her life herself and with the support of others previously. But she was at a particularly low point, I think, and she was feeling like anxious and low confidence. And she reported struggling to leave the house in the morning, and she reported struggling to take her children to school. And she also said, so when we put this case study together, that she was particularly anxious about her first visit with the social prescribing advisor. She thought she didn't know what to expect. And she also said that when she met with Claire, who was bubbly and kind and easy to talk to, it was a great relief to her, and they had a very good first session. They met at a local community centre. They spent an hour discussing Sarah's needs and what would make a difference to help her, anxiety in particular, and her low self-confidence. They met a number of times, and through their sessions, Claire supported Sarah to develop coping strategies and techniques. Alcohol was also an issue in Sarah's life, and she wasn't working. So these were two big issues for her, and also her weight. So through the work that they did together, they were able to work together, and Claire found employment, she lost weight, they worked together on anxiety, and she's now feeling very good and able to take her children out and about and work, which is all really, really positive. Which is on this slide. I've sort of got ahead of myself there. And so what she says in the end, I would definitely recommend anyone who's going through a hard time in their life, don't be afraid to ask for help and accept the help of others. You are stronger for asking. It takes a strong person to admit they need help. And at the bottom, I see life more positively now, and I can see the kids are happier, and that makes everything worth it. So a really positive story. So back to my partner in crime.
So as you said before, it's very much a joint approach, and that is the real strength of the social prescribing model in Shropshire. Because this joint approach has allowed us to bring together the expertise that we need for each area for the model to work properly. It also helps us to use resources better. As Penny said, we've literally done this on a shoestring. And the whole thing has been evaluated. The pilot in Oswestry was evaluated by the University of Westminster, and it gave some really positive results. So there was a reduction in GP appointments of 40%, which I think is phenomenal. And people did make really positive changes, particularly to their health. There was high patient satisfaction, and the unmet needs were supported beyond the remit, so people had gone the extra step. And the model is recognised as good practice and has gained national recognition, which Penny's going to talk to you about. But I wanted to say that the flexibility that has been built into this model because of the way we've developed it, again, is another real strength, because it allows us to meet the needs in each geographical area, because we all know how different those are across Shropshire, but it also allows us to meet the needs in each surgery, and that's really important as we go forward, and particularly as social prescribing becomes much more mainstream within the healthcare system.
Only briefly, I thought if we were going to put a statement up there like model recognised as good practice nationally, we better have something to say about it. So it is in the Public Health England Toolkit Best Practice Guide on Community-Centred Approaches. I can send links if anyone's interested. It's the HFMA, Health Financial Management Association. It's in one of their publications, The Value of Community Services, Enabling System Working. And also Bromley by Bow, which is one of the key areas we looked at, and one of the originators of this kind of model of social prescribing, had an exploration of community approaches, can't even read my own writing, to social prescribing services, and so we're listed in there as well throughout that documentation. So it's nice to see, I think, locally, something we've worked so hard for and there's been such enthusiasm for is being recognised. And I think we should probably mention Jo Robbins as well, who's been leading this for us locally. She is the regional coordinator for social prescribing, and will still continue to be linked in with her, but she has spent the last few years working with us on this. and with great enthusiasm. Was I doing the last slide? Yeah. So what next? So we're really hoping to continue to develop with our primary care network partners. We're working with the Southeast and the Southwest currently we already are working within some of those practices, but we're expanding those to across the Southeast and the Southwest, which is really exciting. We're hoping to work with Central and North as well. Those are conversations still to be had. We're developing ideas around children and young people. So what is it that we can do working in that space? And I think also the reason why, I remember actually really well, it was Paul Cronin that said at our first event in Oswestry, this is something really positive for the voluntary sector because this could prove the voluntary sector's worth. We all knew the voluntary sector's worth before this, but this could demonstrate through the evaluation the worth, and it has done. It's shown that people are being supported by the voluntary sector. It is improving their health and well-being, and from that we can work more closely together and support the voluntary sector in the work that they do. And so that's a conversation that we continually need to have, and we need to bring forward in the strategic area as well. And I think that's it. Are you okay? Thank you.